Hi, everyone. Thanks so much for joining us. We're going to get started in just about 1 minute.
Hi, everyone. Thanks for joining us today. My name is Aisha, and I'm a Senior Policy Analyst at CLASP, and I'm joined by Dr. Kima Taylor, who is the Principal of ANCA Consulting and one of our Mental Health Advisory Board members. Today, we are going to be talking about how the history of racism is negatively affecting our response to the opioid overdose epidemic in all communities. So to go over what we're going to talk about for the next hour, we're going to get some insights as to where you're coming from on this topic. We're going to give you some teasers if you haven't seen the report that we released earlier this year called Between the Lines, Understanding Our Country's Racialized Response to the Opioid Overdose Epidemic. We're going to talk about a historical timeline just to give you more context to what we're talking about of unjust and racist policies that brought us here today. Kima is going to lead a discussion about what we have learned from this and where we can go from this point forward. And we would be remiss not to talk about the intersections between the opioid overdose epidemic and COVID-19. And then we're going to go into a Q&A. So just so you know who we are, I'm Aisha Weerasinghe, and I'm going to give you a little bit of some stats and really trying to set the context as to where we're coming from at CLASP on this topic. And then Dr. Kima Taylor will be talking about how we're going to move forward from this point. I wanted to just go over some logistics to start. So we really welcome your questions and comments. And if you could put those questions and comments in the chat box, Kayla Tawa, our colleague who's supporting us on this, will go over those questions and comments at the end, and we'll come back to them. Please have your phones ready for text and online polls, and we're going to also drop the poll links in the chat box as well. And this webinar is being recorded, so we are going to send out the recording and the slide deck after the presentation. And also we have a couple of handouts that we're going to send out as well. So we wanted to start by talking about who we are at CLASP, the Center for Law and Social Policy. For those of you who don't know, we're a national, nonpartisan, anti-poverty nonprofit, and we work on policy solutions for those living in low-income households. CLASP works under 6 policy teams. I sit under the youth team, which is one of 2 teams that focuses on a population, and when we're talking about youth, we're talking about those who are ages 16 to 24. We have a childcare and early education team as well. We have an immigration and immigrant families team. We have a job quality team, which is a team that focuses on fair scheduling, paid sick and family leave, as well as other supports like that. We have a post-secondary education and workforce development team. We have an income and work supports team that focuses on supports such as TANF, SNAP, Medicaid, and is also focusing on public charge. And we also have two cross-cutting teams. So we have a cross-cutting team that focuses on criminal justice, and then a cross-cutting team that focuses on mental health. And both of those issue areas are very relevant in the topic that we're talking about today. So the way that CLASP approaches our mental health work is in specifically looking at two populations. So both the youth team and the childcare and early education team are the some of the two teams that work more specifically on these areas. So we focus on youth and young adult mental health and well-being and maternal mental health as well. And our mental health work focuses on both the federal and state areas, looking at policy analysis and advocacy. We also do technical assistance on the state and for state and localities as well. And CLASP has what we call learning communities, which are an opportunity for states to be able to talk to each other and learn about topics, specific topics that we feel are relevant to the national context. But we also want to provide opportunities for states to be able to learn from each other in terms of best practices and challenges, because we feel like that is a service that we can provide. And all of our work is guided by an advisory board, of which Kima is a part of our advisory board, comprised of experts that we value so highly, and who also have not only content expertise in terms of learned expertise through academics, they also have content expertise in terms of lived experience. We wanted to flag that we've been recognizing Mental Health Awareness Month, which is, of course, as you all know, in May. And we've taken over the hashtag Reframe Mental Health to really think about this time as an opportunity to reframe how we think about the mental and behavioral health systems and think about ways that it can be changed. And we have a number of resources that we've come out with recently and are continuing to come out with throughout May and probably into June. And we also have profiled a number of our partners on Instagram, and will continue to do so throughout May. And this webinar, as well as a couple of other webinars we've had throughout the month, are what we're releasing in honor of Mental Health Awareness Month, and we encourage you all to check them out. So as I mentioned, our mental health work focuses on policy change and also system change in the health and social service sector. And a huge part of our work is thinking about how race and ethnicity affect a person, the way a person interacts with the health system and receives services. And I mentioned this here in the context of the opioid overdose epidemic, because from CLASP's perspective, unless we figure out how to make significant upstream economic and social policy changes, we're going to continue to see inequities in prevention, screening, and treatment, which will, of course, continue to result in greater health disparities in opioid overdose and substance use disorders overall. So we wanted to start by asking you all where you're joining us from, and if you could go to the website that we've listed at the top of the screen and pinpoint where you're coming from. We'll give you about a minute so we can see where folks are joining from. And I hope this is working. Okay, so we have a couple of answers already. A lot of folks from Pennsylvania and maybe Maryland and Delaware, New York. Missouri, California. Canada. Great, this is probably testing my geography skills as well. Great, thank you all for joining us today. A lot of folks from Pennsylvania, that's great. All right, I'm gonna switch to the next slide. We want to know if you can tell us what you're hoping to gain from this webinar. So if you can either go to the website or text Youth Team 426 to the number 22333, and it'll give you a reply message, and then you can text your answer. So you have another participant from New York. That's great. Let us know what you're hoping to gain from this webinar. So we have ideas that we can implement in our programming. That's great. It's a good flag for Kima. Hoping to pass on the message. Great. Information regarding what I can do in my state for social justice and other disparities with minority populations. A framework to think more critically about drug policy change and the impact of structural racism. You came to the right place. How to address systemic racism in OUD treatment, especially as it's been publicized as a problem for white people. To educate myself and share information with my team. Helping my community and people I work with to better understand and come up with solutions to help this community. That's great. I think these answers will really help us frame the discussion at the end of this. And I'll read two more before I go forward. So I work with incarcerated youth who primarily reside in areas of poverty within the Central Valley. Their lives revolve around racism and the stigma of it regarding drug overdose and gang violence. My hope through this webinar is that I can further understand racism as a white female. And then finally, we have a home visiting program called First Steps Together that assists mothers that are in recovery. I'm here for information that can help us. Thank you so much. Thank you so much for providing your responses and what you want to gain from this. And we'll hope to address as much as we can in this hour, and also we'll give you our contact information so we can continue the conversation beyond this webinar. So I wanted to start by talking about these two graphics, which are in the paper, the Between the Lines paper that I referred to earlier in this webinar. So both of these graphics are representing the same thing, but in different ways. So they are talking about the rate of overdose deaths due to synthetic opioid use, not methadone use, from the years 2016 to 2017. So on the left-hand side, you can see the rate increases by race, and what we see a lot in media and the national context, even in public health as well, is how the opioid overdose epidemic is really impacting white populations. But if you look on the right-hand side, when we think about the percent change in opioid use, although overall rates may be higher among white populations, the percent change in overdose deaths, particularly in Black non-Hispanic people and also in American Indian, Alaska Native people, and I'm using the terms by which are used in the data, the percent change is the highest. So 60.7% for Black non-Hispanic people and 58.5% in American Indian, Alaska Native people in terms of overdose deaths due to synthetic opioid use. And this is only in 1 year, from 2016 to 2017. And this is based on recent CDC data. So these rates, although staggering, they could also be underestimates, and that could be due to limited data collection in these populations, underreporting as well. Contributing factors to these staggering rates can include, but are not exclusive to, but could include the lack of belief that substance use is linked to physical health, could include the limited access to opioid treatment programs. They could include limited access to rehabilitation facilities. They could include a sense of hopelessness and historical and cultural trauma as well. And they could also include a lack of education on the dangers of opioids. So any number of these factors could contribute to the higher substance use rates, but they're not the only reasons. It's really important for us and indicative for us to understand the connection between these factors and systemic racism and discrimination. So I included this map here. It's not included in our paper, but just to talk about the intersection between poverty rates and drug overdose death rates. So this map does talk about not only about opioids, but drug overdoses overall. As you can tell from this map, it's a little bit hard to see, but the more red the areas that are more red have higher overdose death rates, and this is probably not surprising for many of you. And those that are more purple have higher, are areas of higher poverty, with higher poverty rates. And then the intersection of the two is this maroon color. So from this map, which is from ASPE, the Office of the Assistant Secretary for Planning and Evaluation, some states with the intersection between higher poverty and disproportionately higher rates of drug overdose deaths include California, Alaska, Washington, Idaho, Montana, Arizona, New Mexico, Colorado, Oklahoma, South Dakota, Missouri, Kentucky, Ohio, West Virginia, and Maine. And I'm guessing from where a lot of you are coming from, you know this already, which is why you're here today. So just to give you an overview of what it's looking like across the country. So when we're talking about how poverty and race contribute to the epidemic, of course, poverty can be caused by racist and discriminatory policies in housing, immigration, barriers to public benefits, limited access to jobs, food, and other opportunities to help communities thrive. You can see this exacerbated even through the pandemic. Harmful policies over generations have systematically excluded communities of color. This does not exclude our healthcare and social services systems, which actually exacerbate and contribute to these barriers. And we're going to talk about more about what happened shortly. So this timeline is a representation of policies that have contributed to the opioid overdose epidemic. It's not comprehensive. One could make arguments that laws put in place when colonists first arrived to the United States or when the first slave ship arrived in 1619 have impacts on the rates that we see today. However, we wanted to highlight some key time frames when policies were put into place that you can see the through line between what happened then and how it's impacting people today. So here are some examples from 1696. Laws were placed to strike fear into white people and dehumanize Black people. In 1875, San Francisco ordinance criminalized the smoking of opium in smoking houses or dens, which could be interpreted as an economic ploy to hurt Chinese immigrants. We see some of that even today. In 1914, the Harrison Narcotics Act was passed, and it was the first congressional action to counter the US drug trade, which used the police, law enforcement, and taxes to enforce the law. And in 1934, the National Housing Act was passed to solidify and exacerbate redlining. You'll see here that social and economic policies went hand in hand to dismantle capital of communities of color and the livelihoods of communities of color. So that included those who are Black, Native, Mexican, Chinese, and the list goes on. In 1969, President Nixon called a war on drugs, as many of you know, which created treatment programs and increased law enforcement in Black communities, which created justice and equities. So I wanted to read this quote, which I'm sure a lot of you know already, but just to really talk about what we're talking about here. So this was from John Ehrlichman, who is Nixon's domestic policy chief at the time, but he admitted this many years later. We knew we couldn't make it illegal to be either against the war or Black people, but by getting the public to associate the hippies with marijuana and Black people with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did. So we put that quote there just to really hammer home how this way of racism has been indoctrinated into our policy making and continues to do so in different ways. You can make the parallels between that statement and what we see today. Federal laws were then further placed and put in place in the 70s and 80s to further criminalize certain communities. But I don't want to not acknowledge the efforts in harm reduction that came about with state and local intervention in between. We've seen some federal policies put in place in the last 30 years or so to help rectify some of that damage that was done. It was done through and we're talking about positive pieces of legislation. We're talking about the Mental Health Parity Act of 1996 and that updated version in 2008, the Drug Addiction Treatment Act, Rockefeller Drug Reform in 2009, the Fair Sentencing Act, and studies done by the Institute of Medicine. In recent years, we've seen the passing of CARA, the Comprehensive Addiction and Recovery Act, and the SUPPORT Act, the Substance Use Disorder Prevention that promotes opioid recovery and treatment for patients and communities act. It's a mouthful, which as national advocates we're working to ensure are implemented. But we also want to make sure that those are not considered the be-all, end-all of substance use prevention and treatment bills. We want there to be a federal response that really looks at all of the elements that I mentioned earlier. So with that, I'm going to pass it over to Kima.
Hi, how are you? First, I want to thank Aisha and the CLASP team for inviting me to participate in this webinar. I'm quite honored. And for my piece, as Aisha said, it really is trying to look at the timeline and see what it's telling us. And at the end of my conversation, I would say, three main points. One is that we have to change the way we think. In the past, we used racist responses. We need to eradicate these and develop and fund a rational, equitable substance use service system. Two, it has to be paid for. Public and private payers must pay for and evaluate the outcomes of community-based, culturally effective continuum of health and social services for people who use drugs. And this requires not only looking at the continuum, but looking at stratified data to make sure we're achieving better outcomes for all and reaching health equity. And lastly, such systemic change is going to require a change in education of the system and the people within those systems and the public as a whole, if we really want to achieve better outcomes. So before we start talking about some of the micro lessons learned from the timeline, we really have to be honest about the macro lesson and whether we genuinely want to change the reality highlighted in that timeline. We have to ask ourselves, do we truly, as a country, affirmatively believe in justice for all? Do we care that people of color are being punished and dying at higher rates? Are we ready to do something about it? Are we ready to let go of the public's anger towards people who use drugs? How committed are we to see all populations survive and thrive? Without the true belief that all people should be created equal, that no one is inferior or lesser while others are superior, that people's worthiness should not be a measure that is granted by virtue of race or wealth or other characteristics, but that we are all worthy, and without the true belief that human rights are for everyone, system change isn't going to happen and outcomes will not improve or will not be sustained. Our history of response to drug use keeps recycling itself in sad, horrid ways. While this talk is related to health and opioids, those two permeate all the systems we hold dear: health, public health, education, employment, child welfare, and many other systems that must fundamentally change their infrastructure to improve health for all. Next slide. I should say that, Aisha, next slide, that my slides are more a guideline to the talk and not necessarily completely followed. So the timeline that Aisha just presented shows you a race and oft economic-based response to drug use, not a health-based one. Punitive responses were designed to punish and exclude different races. To change the social, economic, and health outcomes of the impacted populations, we have to change the basic frames. Again, the justice system was not meant to be a remedy. It was meant to be a punishment, as was shown in Ehrlichman's quote. Comparing outcomes to something that was not meant to be a remedy is not helpful. It is like comparing someone with high blood pressure on a beta blocker alone to someone with high blood pressure who's left in a tiny hot room with lots of stress and salty food. Research on hypertension doesn't compare that latter person in a box with salty food and compare it to health and social services. Instead, it compares someone who's on the beta blocker, which may or may not be effective for everyone, it's not, to people who are on other drugs that are effective for them with the health and social services they need to thrive. The same must occur for substance use, especially if the remedies themselves are rife with disparities. For instance, okay, drug courts are better than prison for people with substance use. But again, prison was not meant to be a treatment for substance use. It was meant to be a punishment. But even as drug courts are better than prison for people with substance use disorders, these too can create inequities and disparate incomes based on who gets chosen, who's put back in prison rapidly for technical violations, whether the care is evidence informed. If we know there are inequities baked into these remedies, shouldn't we do better? Isn't that a wake-up call where we regroup, talk to individuals, families, and communities and all of their stakeholders to change systems and provide, as with hypertension, health and social service responses? Next slide. So I think the lesson we learned from that is that we need to really look at what outcomes we'd like to see, and we need to base them on what are positive outcomes, health and social service outcomes for people. The next lesson we learn is it cannot just be about opioids. History has shown us myriad drug crises with different drugs as the foci. We often half respond to each crisis, vilifying people and not providing services, and then feign surprise when we're unprepared for the next crisis, or we then go ahead and vilify another group of people. The AMA recognized alcohol addiction as a health concern in the 50s. There have been health responses to opioids since the 1900s. Mary Todd Lincoln had an opioid addiction. Let's prepare this time and create a system of substance use services writ large. Most recently, with the current opioid epidemic or crises, it was decided that opioid use is a public health issue for some people. We need to expand this thinking and rhetoric to all drugs, not just opioids. All drugs require a culturally effective health and social services responses. We can't afford a two-tier response with certain remedies for white people who use opioids and different responses for everyone else. At times when I say this, people will say, oh, absolutely understand about disparities. That's why we want to make sure that people in jail get access to treatment. And they really support treatment in jail and prison. Not only is it a little hurtful when that's said to me as an African-American woman, but it's not comforting and it's not fair, not the least of which it doesn't take into account the negative health and social and economic impacts of being in prison, nor the collateral consequences upon release, even if substance use treatment is received, which help increase those race and ethnic disparities. We need an integrated, funded, culturally effective, community-based system that supports evidence-informed substance use services for all. Next slide. The other thing the timeline has taught us is we cannot have a standalone treatment conversation, nor can we have a medications for opioid use disorder or nothing conversation. If we're truly going to build a substance use system, yes, please make sure people are provided and offered medications for opioid use disorder, just as you would provide insulin for type 1 diabetes. But it's more. And what if that provider for the insulin, in the type 1 diabetes example, has implicit bias towards certain people, doesn't want to give insulin to some people, deems some people worthy of insulin and others not so much, or only wants to provide insulin for people who use it perfectly, and for others, they don't deserve it. This wouldn't fly and should not fly. There are disparities in other health systems, so sometimes it happens, but we recognize it's wrong. In the substance use sense, we've accepted that, and it should not fly for substance use. Sectors should have conversations about creating a system with a full range of substance use services that are culturally effective, evidence-informed, easily accessible, and community-based, just like we have for other health concerns. So many policies and localities presuppose treatment, and maybe treatment and recovery are the only conversations or the only ones that require and are worthy of inclusion and parity. But for improved outcomes, private and public payers, Medicaid and Medicare, and plans must include coverage for a continuum of services, including prevention, harm reduction, formal and informal treatment, recovery services, mental health, physical health services, and services that address social and societal determinants of health. For the uninsured, public health funding can cover these services. Access and outcomes must be measured across diverse populations to ensure they are effective. And I repeat, private and public players must fund a full range of harm reduction services. I reiterate those because those are the ones that are often left out for moral and non-science-based reasons. Due to the racist and morality-based history of substance use, we've not done our research. We have to start funding honest use research. But in the meantime, we must also look to and fund community-innovated solutions that were developed when government and health systems ignored drug user health and well-being. Communities have survived despite our punitive laws and hostile attitudes, and so we need to look for those nuggets that have helped that survival. And I use an example during HIV and the advent of syringe exchange. People thought communities had to figure out ways to keep their loved ones alive despite government animosity. This has been proven to be effective and needs to be expanded. We need to have less selective use of data. So again, saying X is better than jail is not really the right answer. The right answer is X actually creates improved health outcomes and or even saves health or systems funding. So what does help with HIV prevention? What helps to decrease the amount of wounds? What helps to decrease the amount of bacterial endocarditis? What helps people get employment? Those are the outcomes we need to look at unto themselves and unto the population, as opposed to whether these outcomes are better than prison and jail. We need to develop and support current effective engagement and care services and assess the efficacy across different populations, recognizing that one size does not fit all and doesn't have to fit all. Health payers and systems pay for innovative engagement for other health concerns all the time. The same needs to happen with substance use. And finally, we have to consider equity and the substance use continuum, and in all areas collect stratified data. We need to be prepared to assess quality and change or improve services as needed to improve outcomes and eliminate disparities. This is best done with community involvement, community broadly defined, but with thoughtfulness, because as you go back to the history and the timeline, we've really shown that society has been angry at and dislikes drug users and has often punished them, and so taking that balance into account. Next slide. And so the timeline does show the laws and the punitive laws, but it really doesn't give a full picture of the outcome and the fallout of those laws. The morality and punishment frame perfused all of our responses and requires us to rethink myriad systems. One I like to focus on that doesn't get paid much attention to often is taxation. And taxation does not necessarily equal cessation of substance use for people with substance use disorder, even as it offers preventative benefits. If people still have a substance use disorder, they still need the substance to carry on, even as we use taxation and increased pricing as a tool to promote prevention. So this means ensuring easy access and funding to harm reduction, informal and formal treatment, recovery, physical, mental health, and whatever other social and health services are needed for people to be as healthy as possible. And I often use this idea that it's not enough to say we're gonna like tax things tons and then offer treatment. And I use this in the sense of what happened to Eric Gardner. Tobacco is legal. People who have a nicotine need and are addicted to cigarettes need to get their cigarettes. When it becomes too expensive to get cigarettes, people then pay for small amounts of cigarettes or loosies. Then that becomes illegal to sell certain things, and we have really horrendous outcomes because our systems were fundamentally built on a framework of punishment and racism that leads to tragedies like Eric Gardner. And so we really have to think through not only the laws, but the fallout along the continuum of the disorder, such that taxation as a prevention tool is important, but not enough. And this is not new. Think about diabetes, right? You tax sugary drinks to prevent people from having too many sugary drinks in order to decrease type 2 diabetes rates. But for those that do have type 2 diabetes already, you still offer a full range of harm reduction, treatment, recovery, and relapse services, even if they don't have a perfect hemoglobin A1C. So even if they're still using drugs, you have to offer the same. And even when they don't have a hemoglobin A1C, we actually often offer more engagement, change our engagement types of services in order to help engage and keep that person as healthy as possible. We have to do the same for substance use. Lastly, we need an adequate funding for and support for culturally effective, evidence-informed, community-based services that meet people where we are. And that will require other systems to change as well. Child welfare systems seem to default to removing children of parents with substance use, while rules and programming are often written in ways that don't support the eventual reunion or make that more difficult. Removal patterns are also rife with disparities, and support for parents can often, even as we know that supports for parents can often lead to positive outcomes for parents and children without removal. However, the system needs education and support to make such fundamental changes in the way they support equitable outcomes. The same needs to happen across juvenile justice systems, adult justice systems, our education system, employment system, and others. Next slide. second to last slide, I really want to highlight something that Aisha said, and that a lot of times we use the punitive laws to hide economic scapegoating. So in terms of the early opioid laws, a lot of the state level prohibition of marijuana was targeted towards thinking that marijuana came from Mexico and you didn't want to have people who were Mexican coming and taking jobs. And so they said, oh, we'll link those two together, create punitive laws and keep people from coming in. And so in the past, people really wanted to exclude races from economic systems, and they often used drug laws to quote unquote protect drugs for quote unquote Americans, which was really white Americans, right? I find this incredibly important to mention right now when unemployment rates are incredibly high. We have to be careful with new laws, rules, and regulations that worsen racism and inequity in the name of job protection. We need equitable access to employment, equitable access to employment mobility, and we need to require that statistics are kept to see how we're doing. And all of the punitive laws do not lead to positive health outcomes. They rarely lead to really high quality jobs. But what they do is allow for these racist frameworks to continue. Aisha, next one. So really, ultimately, what it comes down to is to philosophy and financing. We can't hedge our bets. It requires the systems and the people that work within those systems, as well as the general public, to profoundly change. Substance use is a health concern, which requires health and social service response. Our history has shown we never understood this, and we have not put in place systems that can provide such culturally effective health and social services. Now it's the time to think through not only how we create such a system, but how we do it in a way where all races, ethnicities, genders, sexual orientations, and other intersections are treated equitably. During this time of COVID, a lot of these disparities have been highlighted, and people keep highlighting them. This is not the first time disparities have been highlighted. Now is the time to stop highlighting and start creating action and thinking of ways to change. The system is so broken that this is the time that opens a window to really rethink the way we treat people, rethink the way we keep statistics. So we are keeping stratified statistics and allowing people to identify who they are and looking at that data to see if we're actually providing improved outcomes for drug users, but not just in the substance use space, how their physical health is, how mental health is. And especially during this time of COVID, as Aisha mentioned, people are starting to think a little more about mental health. And all of these changes are really going to require leadership, funding, community engagement, and development of resources, and a proactive decision to leave racism behind. Last, I would say the conversation cannot be just about Medicaid. It can't just be about opioids. It has to be about private funders. It has to private payers. It has to be about Medicare, Medicaid, education systems, governments writ large, not only changing the way they think about how their system should act, but using their gravitas as payers, as contractors, as people who have a duty and a job and are tasked to really improve population health, to use that gravitas to force other systems to change as well. And so that actually wraps up my comments.
Great, thank you, Kima. So before we move on to questions, we wanted to ask you, just to start the discussion, how does all of the things that we've discussed in the past 40 minutes or so, how does this show up in your work, or how would you like to show up in your work? So if you could respond by texting 22333, youth team 426 to 22333, or following that web link. We'll start there, and we'll give you a minute or so to respond. And I'll say, as you're responding to this, if you have questions, if you could put that in the chat box, we'll get to those after we do this poll. How about while people are putting in answers, we could go to questions. Kayla, do we have any questions so far?
Hi, we don't have any questions yet. If anybody has a question, please add it to the question box.
So Kima, I have a question for you while people are, if people have any, are coming up with their questions. What do you think, as we've been presenting these statistics in the timeline and kind of the framework, if someone is recognizing the concerns within their community, what do you think would be the first steps in terms of education of colleagues, but also in terms of thinking about a system change and eventually leading to a policy change? I don't know if that question is too broad, but.
No, yeah, I think so. We always say get the data, and I think this is one of those places where you're not going to have all the data you want. And so that gap of itself will help propel people. So by that, I mean, there's a lot of information perhaps around certain groups and overdose. And for sure, often white groups with overdose, Black groups maybe, but we have this horrible data thing where we go white, Black, other, white, Black, non-Hispanic, other, and slowly you might get more definitive or smaller subgroups, but rarely. And so that lack of data should be a wake-up call. And just comparing it to, often you'll have the census of who's in your community, and then you'll have on the other side who you're actually collecting data on, and that should demonstrate a gap that needs to be filled. I think the other piece that is a bit of a wake-up call in many communities is the fact that methamphetamine use is rising. And now when people are looking at some of their overdose data, there's more drugs in there than opioids, and for sure more drugs than prescription opioids, right? Including fentanyl and others, and people who would have used cocaine, and now cocaine is laced with fentanyl and dying. And so I think that's another conversation to have, to say we need to create a system, and then compare that, well, looking at who's actually getting services, often for workforce and other reasons. As you mentioned, they're not credible access to substance use service, but also often the services are not culturally effective. They're not evidence informed. They may not be collecting outcome data in stratified ways that shows quality. So really, I think doing a landscape analysis of who's out there, who's really out there, what are the services they're receiving, and what are the outcomes you're achieving, and not only looking at the data that exists, but really highlighting the data that doesn't, so you can start working with community, I would say, to formulate Plan B.
Great, thank you. And I would also say to build unlikely partnerships. I think that is something that is really key too.
Yeah, and can I actually add something on that? Because I think that's incredibly important. And
Sure.
one of my issues I have, missed opportunities I find, is that people often say we should treat drug use as a public health concern, and they focus solely on public health systems and departments and ignore the health system that has all the money that's actually paying for the care that exists. So really understanding and working with your Medicaid departments and your private payers, and requiring and holding them accountable for providing the whole continuum of services, for really, and often they haven't thought of, but like, how do you create those community relationships and partnerships that can make that happen?
Great, thanks, Kima. I think I was hoping that the technology would work throughout, but it looks like maybe that last poll didn't work. Kayla, do we have any other questions?
I don't think we have any other questions. That last poll, I apologize for the technical difficulties, but it doesn't seem to be working. But if anybody has a question, you're welcome to put it into the question box. I did get a couple reflections for the last poll that wasn't working. So we have opioids and other drugs do not discriminate based on race. This is so true. We must be true to the issue in order to help conquer the problem.
Yeah, and can I actually, so one thing about that, everyone uses the phrase now that substance use doesn't discriminate. And I want us to be thoughtful and cautious when we use terms like that, because it often can help discriminate depending on who's using it. And what it does is then it glosses over the need to look at really stratified data. And it says, well, if we offer buprenorphine, if we expand the use of buprenorphine, then everyone will get treatment and, overdoses will decrease. And then you look at the data dive and you're like, well, white people are more likely to be offered buprenorphine than Black people. And so it really, that making sure that when we say that, coming with that is that real look at your populations and what their actual outcomes are. Because unfortunately, in a lot of the advocacy, that has led to this focus that has allowed the overdose rates in African American and Native American populations to increase, quote unquote, under the radar. Not on the radar if you're in the community, but under the broader radar. And I do have to put in, since there's no questions, one more plug and thought around harm reduction. When I'm talking about harm reduction, a lot of people then think that's just naloxone. It's not. And it really is the care and thoughtful respect and providing services for people who use drugs, continue to use drugs, aren't going to treatment, and ensuring they're as healthy as possible. So some of that is syringe exchange. It's funny because medications for opioid use disorder used to be thought of harm reduction, but it's also for people who are not using opioids. And so for methamphetamine or crack, it's mental health services, it's the whole gamut of services that keep people as healthy as possible. And our systems have not paid for that in the past for really moral, non-science-based reasons. And that, I think, is a step that people can start thinking about how to include that in some of their funding packages, perhaps starting with the public health system until we get private and public payers on board. But that really is, if you talk about any other chronic disease, we provide that harm reduction piece, and this is one where we don't on a regular basis.
Kima, if I can add to that too, I think if you think about what opportunities there are through this, the COVID-19 crisis as well, we've seen a lot of relaxed or quote unquote relaxed policies in terms of telehealth, et cetera, as Kima was saying earlier. But there are some gaps when you're thinking about who is accessing what, whether it's buprenorphine or methadone, and how they're able to access it, particularly thinking about social distancing and who's being able to take home medications and who's not, and who has to ask for additional clearing from providers and who doesn't. So there are things to really keep an eye on in terms of state and local policies, and to flag that for policymakers.
And provider bias, right? It's kind of like the insulin person. There's so much baggage around methadone, even though it has been proven effective, it has been around the longest. And that baggage and racism comes with it. And so even if you have a law, which is, methadone, you have to be seen in person first, whereas bup you don't. And I just said that bup is more likely prescribed to white people. So there's all this stuff built into it. But even if you get past that and there's a law saying that you can then give longer take homes for methadone, a lot of providers won't. And so it's also that implicit piece that's built in that, you get to say, well, I will give insulin to this person, but not to that person. And it's not, it's something that we need to unpack, not even necessarily vilify, but unpack so we can improve. And you're absolutely right. COVID is heightening that reality.
So with that, if we don't have any more questions, we can end a little early, but I just want to reiterate that we will be sending out the slides and the recording after this, as well as the paper that we were referencing and the timeline. And we're also going to send out our list of policy recommendations as well. And please consider us as a resource. Either these are Kima's and my email addresses. If you have specific questions for your state or locality, we're happy to provide any assistance that we can, or connect you with other folks. So we hope that you gain something from this hour, and hopefully this is the beginning of a longer conversation. Thank you.
Thank you.